Good afternoon, and welcome to the 16th Annual Margaret Pittman Lecture. I'm Tom Insel, the Director of NIMH, and I'm delighted to be here to introduce our speaker. It's become a bit of a elevator speech at NIMH, so when people say, what are we about, we often say we're about brain diseases. And I suppose if there's one person who we would point to as the explanation for that, it would be today's speaker, who by no coincidence is actually a neurologist and not a psychiatrist, but arguably has done more to help our understanding of depression as a brain disease than anyone in the last several decades. Dr. Helen Mayberg is originally from Los Angeles. She was a graduate of UCLA, went on to get her medical degree at University of Southern California, and then prepared for training in neurology, doing a residency at Columbia, later a fellowship in nuclear medicine at Hopkins, where she continued on for a couple of years before going to San Antonio for her first faculty job, and ultimately moving to University of Toronto, where she had the first Sarah Rotman Chair in neuropsychiatry. About 5 or 6 years ago, she was recruited from Toronto to Emory, where she has continued to serve now in a endowed chair. It's the Fuqua Chair of Neuropsychiatry in the Emory Department of Psychiatry, and has continued to, at Emory, pursue this passion for trying to understand the neurobiology of depression by working out the circuitry that underlies many aspects of depression, which she'll talk about today. It's probably fair to say that her work has been the most important for helping us to bring circuitry into the study of mental illnesses with a precision that we haven't had before through the use of neuroimaging. And now increasingly she hopes to bring some of the genetic questions to try to inform some of what we know about the circuitry. I want to take just a moment before finishing this introduction to point out that the Pittman Lecture is something that we do really as a special occasion once a year. It's given by a researcher who's dedicated to advancing and improving the careers of women scientists. And the lecturer each year is a woman who's chosen, who demonstrates through example and has made significant contributions to mentoring women scientists. Since 1994, when the annual lecture began, every speaker has exemplified the intelligence, scientific excellence, and drive that made Dr. Margaret Pittman a leader at NIH. Dr. Margaret Pittman was, of course, the first lab chief to be female at NIH, a job that she took on in 1957 when she was named the head of the Laboratory of Bacterial Products. So all of that information and much more is in this flyer, which I recommend that you take a look at. The one thing that's not in the flyer is we're doing something a little bit different today from our past. We are having a reception, but instead of using the lobby, we'll be using the library. And I recommend at the end of Helen's remarks, and after we have a bit of time for questions, that people use this door down here for the reception, where there'll be a chance to ask Dr. Mayberg even more questions about her spectacular work. It's a great pleasure to have you here, Helen. Congratulations on this honor, and we look forward to hearing about tuning depression circuits using deep brain stimulation. Welcome.
Thank you. Appreciate it.
Good luck.
Thank you. Well, it's really an honor and a privilege and a pleasure to be here with so many colleagues over so many years, and to be able to give this Margaret Pittman Lecture. And reading about Dr. Pittman, it really makes it that much more special, because she really exemplified, I think, things that all of us, whether we're men or women, want to do. We want to try to actually translate science into things that help patients. And I think her work in infectious disease, her use of trying to actually do practical work to really implement vaccines, it wasn't just about how good can the science be, but how can it really impact real people. And I think that, I'd like to think that the story I'll tell you about today tries to make some small steps toward that goal in the treatment of major depression. I want to start by both some disclosures, but more to acknowledge a 20-year history of collaborations. As Tom said, that all of this work is done in teams, that ideas are cheap, having people that will work together, have ideas follow through, and feed and nurture one another has certainly been the key to my career. I do want to particularly acknowledge my team at University of Toronto, where actually the implementation of the first cases for deep brain stimulation came to fruition. I have a fabulous team now at Emory with a fantastic surgeon, Bob Gross, and a really superb clinical psychiatrist, Paul Holzheimer, and a group of people in an imaging lab that has grown. We've been fortunate to have support from a number of foundations, and certainly for much of this work, not on brain stimulation, but on brain imaging and depression more generally from NIMH. The work I will describe will led to intellectual property that actually has already been licensed. And the experiments I'll tell you about today over really a very short period of time are actually underway as full-scale clinical trials. So again, how does science translate into real life? Well, we'll see. I am going to be describing the experimental use of a device, and a lot of the work I'll describe will be done under an IDE that I hold at Emory. I want to start by having those of you who don't have depression, who've never seen a patient with depression, have never taken care of a patient with depression, to have a sense of what this illness is like and why, for many people, the idea of a neurologist studying depression seems a little far-fetched. But William Styron, who wrote about his own depression extremely eloquently, this is one of the quotes that I find particularly useful. The madness of depression is the antithesis of violence. It is a storm indeed, but a storm of murk. Soon evident are the slowed down responses, near paralysis, psychic energy throttled back close to zero. Ultimately, the body is affected and feels sapped and drained. He described his depression that it was feeling nearly immobilized and in a trance of supreme discomfort, a very important word to remember, a condition of helpless stupor in which cognition is replaced by that positive and active anguish. There's not one neurological term, there's not one biochemical, but you listen to that and you sort of cringe and kind of go, I hope that never happens to me. And the question is how to actually tease that apart in a neurological way. Before we get to the science, I think the scope of the clinical problem is really important to address because, why do all this? How this is not a rare disease. This is a common disorder, and the World Health Organization says, as I'm sure you've heard Dr. Insel say many times, leading cause of years lived with disability. It is an illness, syndrome of young people. The dogma has been, we have treatments, this is good, take a pill, get a therapist. And what's become exceedingly and painfully clear is not only do our treatments not really get people well reliably, but one size does not fit all. And the idea that everybody can take the same thing, if it doesn't work, switch to something else, is this repeated episode of trial and error to get a treatment. It's actually worse than that, because in fact about 10%, and this is a low number, become what's called treatment resistant, which means that the available treatments don't work for them. If they get them out of episode, it's transient. We've always reserved electroconvulsive therapy for patients that fail medications. It's always been the best reliable treatment, fallback position. We get about half the patients better, but half again and then relapse in 6 months, and then you start again. We've been excited because there have been some new options just been approved by the FDA over the last couple of years, but actually the response rates are wildly disappointing. And in fact, with RTMS just approved in the last year, really doesn't work very well if you've already failed one antidepressant treatment. So it's really for people that don't tolerate meds and that you actually go to it quite early. And vagus nerve stimulation, again, has reasonable response rates out after a year, but actually as you follow people over time, you have an implanted device that the response rates are low. There's been fabulous work out of the intramural program here on scopolamine and ketamine, really insightful studies to actually try to look at non-serotonergic mechanisms, very rapid effects. The question is how long they last. So we have to ask ourselves, what are the limits to innovation? And a lot of this has to do with we're dealing with a syndrome that probably has many etiologies. It has no pathology that's pathognomonic like Parkinson's or Alzheimer's disease. We really have a very undefendable nosology. We follow a Bible that we know does not characterize the illness, and it's reasonably well unless you're actually trying to do science. We've realized that the last 50 years has been driven by a hypothesis that serotonin is definitely part of the mix for emotion regulation. It's very helpful, but it certainly isn't that you're a quart low on serotonin. And our animal models are helpful to a degree. They really have unclear face validity, and we're not even sure that they capture the core features of the illness. So the question is, what do we do? How can we get out of our own box and try something different? And like many things in science, sometimes it kind of just falls out of the sky. I guess it's a dream. There's usually serendipity. But quite frankly, really the cutting edge of science sometimes isn't about what's completely unknown. It's actually being at the right place at the right time, but actually realizing that you may be at the right place at the right time. And I would say for this story, this is about being at the right place at the right time, which is that structural and functional neuroimaging was available, and that stereotactic neurosurgery had really come to the forefront. And again, these ideas are actually not new. It's trying to kind of piece the pieces together to apply something that's right in front of us. This is the same story they went through with the treatment of movement disorder and tremor. They were really good at popping a hole, making a lesion in your thalamus to stop tremor. They didn't have imaging. They had stereotactic coordinates. Surgeons were very good at making lesions going way back. And this approach to treatment of intractable movement disorder stopped with the recognition that Parkinson's disease was a dopamine deficiency disease and a dopamine degeneration disease. One could map the dopamine uptake with PET imaging, and drugs were developed that actually replaced and corrected the problem. And just like many transitions, drugs replaced surgery, surgery fell to the side, and away we went with drugs until we realized that the drugs aren't a cure either, even in a disease of degeneration of the primary neurotransmitter. But at the same time, people were trying to figure out what the circuit diagram was for motor control and how dopamine fit into this motor circuitry. And this was happening in combination with these various other approaches. And in fact, that in making lesions, knowing the circuit diagram helped them to understand why a lesion in the STN or the globus pallidus, which had been done for 100 years, actually might be substituted by brain stimulation. So again, if we have this model in mind, can that be applied to thinking about depression? So if one takes this neurological tactic to the treatment of depression, what would you need to know? Well, we need to define a circuit. That seems pretty obvious. We need to know what parts of the circuit are responsible for ameliorating symptoms. From that, we might be able to figure out what changes are necessary and sufficient, which, if we're thinking lesion or stimulation, might set up some optimal testable targets. And that is actually going to set the stage, if we can meet this criteria, of thinking about how that might relate to some or all patients. So from a historical perspective, there are lesions to treat intractable melancholia. Over the last 100 years, it all got lumped together. They didn't have DSM, they didn't have good criteria, but there were lesions that you could make reliably in the brain that could alleviate the suffering of this kind of psychic pain. It goes back to Hippocrates' time with trephination. There was orbital uncutting that Moniz won the Nobel Prize for, based on monkey models of animals not feeling so bad if they didn't have an orbital frontal lesion when you try to do experiments on them, John Fulton's work. It got refined. The recognition that interruption of white matter fibers coming out of the thalamus were somehow important. Disconnecting something about deep in the brain to superficially in the cortex was important, and people experimented with trying to refine where that lesion should be. People worked around the cingulate, cingulotractotomy. They moved right around the cingulum bundle. They never got quite under the cingulate. Why? Pretty hard place to reach when you don't know where it is and you're going blind. I think that's the only reason they never moved up under the cingulum bundle. There's modern neurosurgery, and overall, I mean, this is a crude structure-function correlation of if you disrupt something, what are you interrupting, and that might tell you something about the circuit. And so the question one can ask by looking at these lesions is what might matter disconnections is really most critical, because we have disconnections that are wildly disparate anatomically. So if we start to kind of say, let's start over, let's build the model, how might we do that? Well, obviously, with the advent of pathology moving into structural imaging, a lot of the really important early work was a systematic evaluation of patients with lesions. Patients with stroke have a very high incidence of developing a post-stroke depression. If you systematically look at what is the lesion most associated with that post-stroke depression, Bob Robinson, one of the leaders in this, a psychiatrist at Hopkins, showed that the closer you had a lesion to the frontal pole, particularly on the left side, the more likely you were to develop a post-stroke depression. This was followed by not just looking at post-stroke patients. Yvette Chalene did one of the really early pioneering studies of measuring volumes in the brain, focusing on the hippocampus because of its known role in stress changes in basic science models, and found that the hippocampus was atrophic on MRI in patients who were depressed, and it was smaller as a function of how long you went being ill without being treated, kind of a sustained stress model, if you will. This was followed by parallel studies by Wayne Drevitz, who was recently here when he was at WashU, that led to not only identifying decreased volume in the ventral medial frontal cortex and ventral cingulate, but also studies in postmortem, guided postmortem studies to realize that there were decreased glia in this same region. And if one puts this together with the evolving story by McEwen as well as others with stress models in animals, there is atrophy that may actually be related to loss of spines and dendrites in the hippocampus, as well as in the infralimbic and prelimbic areas, the rat correlate of this part of the brain, but an interesting relationship with not just decreased dendrites in certain regions, but increased dendrites in spines in the amygdala. So already seeing, even at the dendritic level, a reciprocity between certain regions, deep, and other regions cortically. Now, the other approach that certainly was the approach that I entered into was looking at functional studies. And I see several of my colleagues that remember this work from, the mid-'80s in the audience, where the idea was look at regional glucose metabolism, take depressed people, it's a very sustained depressed state, take healthy people, take depressed people, subtract the voxels. Everybody who does functional imaging knows this. This goes back well before fMRI. And one can let the data tell you where the problem is. Once again, here's our friend, the frontal lobes. But we start to get an idea that this is an illness of more than the frontal lobe, even at this very macro level. We have the cingulate, we have parietal cortex. We can see this pattern in unipolar depressed, Parkinson's depressed, bipolar depressed. We're starting to see this as more than the left frontal lobe. This is more than the frontal lobe. But the frontal lobe has always been the most common. But like everything else, this is not a homogeneous disorder. That if one looks, and Lou Baxter was one of the first to describe the hypofrontality in major depression in his work at UCLA. But similarly, the idea that this may be the best replicated finding, but one can actually also see the exact opposite with hyperfrontality in depression. So if we're thinking that actually what drives a disorder is something about your frontal lobe, well, we will be sorely mistaken unless we decide that one group doesn't even have the same disorder, which could be true, but they all meet the same diagnostic criteria. I never knew what to do with this. It always also had an increase in the amygdala, which I want everyone to keep in mind. But we ourselves had always seen this pattern of hypofrontality until I met some depressed outpatients in Toronto. And in fact, they also had this hyperfrontality. So we now have a clue that there's variable patterns. But again, we can't be thinking about one brain in isolation. So another way to approach the problem is to say, well, let's control the behavior. I mean, everyone in imaging knows that for many disorders, you actually have to map the symptom or the behavior of question where you can control the variables. Well, we were interested in that as well. We wanted to know, where is the part that makes you feel sad? I mean, in a nutshell, sort of a very simplistic notion. Using sad memory, reliving the experience, not to think sad thoughts, but to feel sad, feel tearful. And in that setting, with blood flow PET scanning, we started to get a notion of dynamics, if you will. We saw that there was a very profound activation of the subcallosal cingulate region, area 25 in the Brodmann map, but at the same time, the frontal lobe turned off. And there was reciprocity between the magnitude of the limbic and paralimbic changes and the magnitude of the cortical decrease. We went to look at this. This was before the time of knowing what an SS and an LL serotonin polymorphism was, but we knew that high neurotic and low extroverted healthy people were a depression risk factor. We looked at high N and low E patients compared to healthy people compared to low N, high E people, and we found that there started to be a shift in the magnitude of activity in area 25 and the emergence of more regions of shutdown in frontal cortex, and that when we actually studied either depressed women or even recovered depressed women, that this pattern shifted in terms of which parts of the cingulate and the frontal cortex were involved. So we have this reciprocity between cingulate, insula, and prefrontal cortex with a sort of graded involvement of medial frontal, which sounds like a hedge, and at the time it was, because we didn't know what that meant. But we started to get some other clues. And this example again, where across disciplines, people at least pay attention to each other. There was a very, very interesting and important observation in a French case of subthalamic nucleus DBS for Parkinson's disease. And this was, you can see the lady, a relatively elderly woman, no past history of depression, had an electrode implanted in the STN. As anyone who is familiar with these surgeries knows, you can have contacts that go deep to the STN, you end up in the substantia nigra. You test in the operating room to know which contact is giving you your best effect, and when they stimulated on the lowest contact in this patient, you can just follow her face over the course of a minute. She went from a neutral mood to being catastrophically tearful. The reports, this was in the New England Journal, is she became overwhelmed, just felt she'd be better off dead, turned off the contact, and it went away. A very important clue. Never been depressed, no clear provocation, provoking an acute depressed state by hitting the wrong spot. This happens not quite as dramatically as this case, which is why it ended up in the New England Journal. But the first week I arrived in Toronto, I was called to try to map a case that was nearly identical. A patient who actually had a history of depression as a younger person, had been in remission for years. On the table, in this case, not in the substantia nigra, but high to the target in the SDN, in the zona incerta, in the white matter, suddenly described, if someone had come in with a gun to shoot me, I just wouldn't have cared. This woman became profoundly apoplectic, not tearful, not this mood reactive like this woman did. I wanted to cry, but I couldn't. It was such a deep down hurt. And for the clinicians, that feeling of I'm dead was really the phenomena this woman experienced. Similar in many ways to being depressed, but 100 times worse. It was like we caught her hyper-acute onset of her depression. And we actually could reproduce this, and we mapped it in the fMRI. And what happened as she went from neutral mood to negative mood is she actually turned off her entire medial frontal cortex. This was identical to women in Texas who had remitted depression, who were provoked by a personal sad memory. Identical pattern, two different methods. Memory evoked, stimulation invoked. And we are now into part of the circuit as zona incerta and the limbic aspects of the basal ganglia feed into this part of frontal lobe. So this was a very important clue and helped us to try to understand this phenomena we'd seen previously. Well, the next step becomes, to really define back to the criteria of We can make people sad. We can see what happens when people have a pathological kind of mood change. We can study people when they're stuck in depression. But what gets better when you actually do something that gets people out of the episode? And so, the obvious, you treat people and you look at state versus trait. You look at being in the remitted state compared to being in the depressed state. And what we saw was actually that in patients that recovered, in this case on a serotonin reuptake inhibitor, this first study was done with fluoxetine. That's all there was. Shows how old this is. But that you suppressed area 25. It had actually been normal to start. It was suppressed below the level of normal. There was an overcompensation with treatment. And at the same time, the hypometabolism was corrected. And the magnitude of each of these changes was correlated with each other and correlated with the magnitude of the impression improvement. This is the absolute reverse. This is over 6 weeks. This is over 2 minutes. This is the exact inverse of what we saw when we provoked with memory acute sadness in healthy people. That we've started to isolate regions that are talking to each other, at least functionally, if not anatomically, because these regions do not have strong anatomical connections to each other. So we have this beginning of this reciprocal interaction. And this, as well as other experiments, we looked at how this network or these regions are changing with cognitive therapy, with placebo, with different medications. And we started to actually just have an accountant's collation of all the regions. Instead of kind of saying it has to be about one region or another region, just kind of say, if it shows up, it's on the list. And to start to try to see how to organize and arrange the regions. And it gets unwieldy. But to try to say there must be a pattern buried in here. And can we start to look for patterns of how different treatments impact this network of coordinated brain regions? And the pattern starts to emerge. Where medication seems to affect limbic subcortical regions most consistently, cognitive therapy seems to affect more medial frontal and kind of cortical regions, but actually they are complementary to one another. And as we know clinically, drug and therapy together is better than either alone. And if they all worked on exactly the same network, what would be the point? Just increase the dose or just use one. So it's already telling us that how we see and take care of patients has to have a biology that matches up. On the other hand, I defy anybody to kind of say that any one node at this point is any more important than any other node, and that became the problem. So as we kind of trudged along, it became very clear that there was something about this subcallosal cingulate region that was standing out. And again, for all of you that do fMRI and struggle with susceptibility artifact, until the last few years, you couldn't get this region of the brain with fMRI unless you actually did some special maneuvers. With blood flow, with metabolism, with PET scanning, as long as you sampled in the brain low enough, no problem. But it became clear that this region, anything you did that evoked a negative state, negative smell, negative sound, negative words, a negative feeling, an emotionally reactive negative state, even with tryptophan depletion, tracking with the magnitude of sadness in people who get sad, a change very selectively in this region. And similarly, as you looked at the changes, you looked at different treatments, SSRIs, SNRIs, even placebo medication resulted in, if you got better, you downregulated this region. And as we started to look at treatments that we didn't even study, you could find, Mark George had found that RTMS in prefrontal cortex could downregulate subcallosal cingulate. ECT in Harold Sackheim and Mitch Nobler's paper on ECT. You start with hypometabolism or hypoperfusion, and the better you do, the more the activity goes down. It made absolutely no sense at the time, but you start to look at it in a new frame of mind, you get a lot of downregulation of activity in areas you may not be focused on, but there's the same downregulation in the same area. And so there are a lot of diverse, unique to each treatment changes, but there seemed to be something important about modulating activity in this region. So you kind of step back and you go, well, what is area 25? And the first person I ever talked to about it, you all know him well and have fond thoughts about him, was Paul MacLean. When I met Paul McLean in Danny Weinberger's lab at St. E's, it's got to be over 10 years ago, I brought his book, I had him sign it, and I asked him, what is Area 25 in your studies? He goes, oh, that's such an old area. That's an area when you stimulate in monkeys, you evoke a separation call. It's key to all of this. He was the first person that told me how important that finding was when there is no natural lesion of Area 25. You can't occlude a vessel. It's very hard to make a lesion there. Tom Insel, when he was at Emory, had done an important tract tracing experiment and showed that it projected down and two synapses on the dorsal raphe and periaqueductal gray. It has a unique set of connections that once one actually sees it, you cannot ignore. It talks to the basolateral amygdala. It receives information from CA1 of the hippocampus. It talks, as I said, down to the periaqueductal gray and the dorsal raphe. It projects uniquely to interneurons in the medial hypothalamus. It's involved in regulating sleep, corticotrophic releasing factor. It's involved anatomically with a direct pipeline to every area of the brain that controls the behavior that we think is important in major depression. An area that nobody would have thought to look at until it told us it was important. It sits unique in its basal ganglia connections to the shell of the accumbens. So its role in motivation is very critical. Those of you who study anxiety disorders, it is part, at least in animals, of the extinction circuit. And if you think about what goes on in therapy for depression, it's about enhancing extinction. So it's a very, very interesting area that if we'd been smart enough to think about it, we would have picked it, or I'd like to think. But the idea is at this point in time, with the advent of imaging, if one now organizes the model to think about Area 25 as the cingulocentric point of view, one can see and find connections that would have it connect to every area that was implicated in all of the other studies of depression. And so we worked very, very grossly, if you will. We had this area that seemed to be important to the negative mood. We knew from the past surgeries that we were kind of in the right neighborhood for where surgical lesions were made in white matter. And we set up, even just working with the surgeon, can you interrupt that region? And we looked to actually not do a subcaudate tractotomy stimulation, wrong place. It's the anatomy that helps you to know that the tracts that get to all these important regions have to be midline, have to be close to actually the subcallosal cingulate and the very important midline tracts. So if we go to start thinking about doing this in patients, we have to remember, who do you do this on? And the issue is that I want you to remember that some patients, every patient actually probably describes this state when you're in episode. The state of being depressed seems to rob you of the capacity to imagine you're any other way. And again, William Styron got better with his depression treatment. What makes the condition intolerable is the foreknowledge that no remedy will come, not in a day, an hour, a month, a minute. It is the hopelessness, even more than the pain. Imagine that actually is true, that you actually have had every treatment and nothing is working, and you pretty much check out in terms of your doctor doesn't have anything left to do, you don't work, you're disabled, you stay home, and you're in this purgatory state. And again, when we think about the course of depressive illness, you're well, you get some symptoms, here's a point, we call it a syndrome, we give you treatment, we consider you a responder if you get 50% better. If you're really good, we get you up to remission. The problem is people relapse. They relapse at different points in time. If you manage to be out a year and you relapse, we call it recurrence. But what we're talking about here is people that no matter what we do, we can't get them well. And as is done in the studies here on ketamine, these treatment-resistant patients are the patients that we targeted. So in Toronto, what we did a classical brain stimulation surgery. Patient is fitted with this contraption, a Lexel frame, that becomes the conduit to the operating room between the MR scanner where you do the surgical planning and actually allowing the surgeon to drive to the proper coordinates to implant this electrode. We use the three-dimensional MRI, and we've gotten much better at using multiple kinds of images superimposed. But to actually, red dot marks the spot. It's very easy to see the subcallosal cingulate sulcus. We use the ventricles to identify the relative anterior-posterior location. 2 burr holes are drilled, patient is awake, the electrodes are dropped, we implant a programmable pulse generator in the chest. It's a pacemaker. And our plan was, we want to turn down area 25. We will use exactly what they do to get depolarization block in Parkinson's disease. We use high frequency, and we'll see what happens. We recruited initially 6 patients. They are very classically highly treatment resistant, nothing very unusual about their onset of illness, how many past episodes. They were on many, many drugs, classically family history and melancholic. And the first study was really to see what would happen. Can you do this safely? So not a placebo-controlled blinded. We had no idea what would happen if you start turning on electricity in an area in the brain that talks straight to your hypothalamus and brainstem. You'd never do this in a blinded fashion like you would do a clinical trial. This was a safety experiment. And so you can imagine our surprise as we started to test in the operating room, stimulating at individual electrodes, when the patients spontaneously started describing, what did you do? I feel calm, I feel quiet, I feel relief. They had all kinds of very interesting metaphors for the experience. Very hard to explain. This is not a cortical phenomena. This is a subcortical phenomena. It doesn't localize easily. But it really was sort of a resolution of the dread, that heaviness. It was like it was an interoceptive release, is sort of the closest I can get to trying to summarize the group experience. But within seconds, once they kind of recognized this was happening, it was like their cortex was released. They talked faster, not in a hypomanic way. They just used more words per sentence. They became more aware that there was an army of people in an operating room that they had been spending the last 3 hours in and hadn't even noticed. Some patients described the color increased. There was clarity. There was more detail. And we had this rough idea that the positive and affective scale was changing, but it was very willy-nilly. But it really seemed as though there was a change in exteroceptive awareness. The best news is that there were no adverse events. I was actually quite surprised that you could be in a tract that went straight to the brainstem, the insula, the hypothalamus, and have no autonomic changes. And these acute effects, not everyone had them, were very helpful to decide which electrode contact to stimulate. You could be at these electrode contacts that are 1.5 millimeters, space to space apart, see it at one contact and not see it at the other. So something very important about location, even though you have a cloud of electricity. So we followed these people over 6 months. It was an open study. We tested them in the hospital. We got this dramatic effect in the first week. They got their IPG implanted. They were off for a couple weeks. They had some regression, not back to their baseline, but they felt ill when they came back in 2 weeks. And we turned them on, and as we followed them, they fell into 2 groups. 2 groups, we're talking about 4 patients and 2 patients, but a very striking, steady improvement over the course of 6 months. And this was accompanied by both a starting point of an interesting overactive 25 and hypofrontality that did exactly what we had hoped. That high-frequency stimulation down-regulated area 25, and what you can't see in this picture is frontal cortex hypometabolism normalized. Now, what wasn't in the first paper was the fact that the non-responders, they had the exact same effect in area 25, but they didn't get changes in medial frontal cortex or lateral frontal cortex. And we didn't put it in the paper, and if 2, it's probably not real. Like everybody knows how experiments go, you file it away. This is what the patient described about what happened, because even though there are these dramatic immediate effects, this is a progressive recovery. And the big question is that acute effect the antidepressant effect, and everything else is rehab, but requires the stimulation to be on long term? What's very interesting about what this patient said is he had a vortex feeling that turned off. It was immediate in the operating room. But what he noticed was that over time, he could be part of his own recovery. He was aware that he could participate and that he actually had to work at it, but that the stimulation allowed that to happen. And I'd like to think that this is giving us a clue that there's somehow a sort of system reset, rebooting, cardioversion, if you will, but you actually have to pace and keep the pacemaker on to maintain the effect. Well, we expanded in Toronto to 20 patients. This is overall the behavior of the patients, a rapid early effect, and it's sustained. Get well, stay well tended to be the story. No dose changes once you kind of found the good dose, no late developing side effects, no tachyphylaxis. Almost kind of too good to be true. The surgeon kind of said, set it and forget it, which I think is a little extreme. Importantly, no neuropsychological testing problems. No price you paid to seem to have 130 hertz going 24/7 in your brain, which again is a very interesting research question. So then the obvious thing comes, well, now what do we do? Well, do we have the optimal dose? Did we put it in the right place? Why didn't everybody get better? Maybe you can turn it off after a while. You know, the usual questions that anybody might think about. But importantly, why didn't everybody get well? What did we miss? You know, good psychiatrists, careful follow-up. Well, we started to look at this responder-non-responder difference. And the obvious first thing is blame it on the surgeons. Probably put it in the wrong place, you know. And it turned out that the average location of the active contact was really identical in the responders and non-responders. So they didn't miss. They put it exactly where we told them to put it in. And if you looked at the cloud of where the active contacts were in responders, we're kind of in the vicinity, but obviously location alone, at least gross location, doesn't explain anything. But in animal studies started to actually be able to answer the question of, well, we already had the clue that just turning down 25 wasn't enough. So the question is if the location in 25 and peri 25 isn't enough. This was an animal study done by one of the neurosurgeons in Toronto, Clement Hamani, where he actually implanted a bunch of rats in the infralimbic white matter, which is the equivalent, and actually looked at the forced swim test. So an antidepressant surrogate, which many of you are used to using. You measure the amount of time that they're immobile when you throw them in water, see how good they swim. You correct to make sure it isn't just a general motoric activity. And infralimbic DVS would have been a good screen as an antidepressant using this test, and it looked a lot like imipramine. So you say, you know, the whole logic had been ablation equals stimulation. So he made a radiofrequency lesion and took out the entire infralimbic region. And in fact, there's a modest antidepressant effect, but actually removing infralimbic cortex was not what drove the effect. And he did what I think is the most important part of this experiment, is he did an imotinic acid lesion rather than a radiofrequency lesion, which damages the neurons and preserves the white matter. In the setting of just the imotinic acid lesion, we get no effect on the force test, but imotinic acid plus DBS, and you get the full-blown effect. This is not about infralimbic, area 25. It's necessary but not sufficient. It's the fibers of passage that are mediating this effect, and the question is fibers of passage where? So we started to say we can use tools now to look at that. We didn't have DTI in Toronto, or if we did, nobody wanted to do it. But at Emory we do, and we started to actually look at what are the fibers of connection going through our electrode. And when you look at it this way, it's really obvious. Depending on which contact you stimulate, you get up the cingulum bundle out to medial 10, down to the amygdala hippocampus, make a turn in the unsuccessful fasciculus. And we went and tracked this to see where is the variation along the subcallosal cingulate. And with Heidi Johansenberg at Oxford, we did an analysis that says there's a split zone in terms of the path maps along the cingulate, the subcallosal cingulate white matter. It's not all the same. Turns out the blue zone contained all of our electrodes. But that blue zone reliably goes subcortically, up the fornix, up the cingulum bundle, out to medial frontal, and critically to the uncinate fasciculus and amygdala hippocampus. And this probabilistic tractography, you can look at an individual which means that you can map the individual contacts for a person and start to see how which one you stimulate by modeling the electricity will actually give you remote effects that are very different. So we went to really nail this down, and this is our study ongoing at Emory, where we're not only looking at major depression, but also bipolar type 2 depression, a disorder with very profound treatment resistance. This tried to make up for and extend the first study in Toronto. It has a blinded placebo-controlled condition at the first month. It looked to actually do blinded discontinuation after 6 months. It had a shotgun approach to mechanism of action to try to get an idea of what might be going on. Very similar kind of population. And I just want to show you that this is really not yet ready for prime time because it's not the full sample. But again, this is during the 1-month placebo period. This is starting active stim, that a big part of the effect is happening quite early. And the trajectory is sort of down and sustained, and this is out to a month. This is the same trajectory that we saw in Toronto with the open study. We took this 6-month time point, we divided into people who met the 50% change pattern or not, and you can see that actually they start to diverge after 2 months. Very similar pattern to what we saw in Toronto, despite the fact that I think we were even more demanding, more rigorous at Emory, because we could be choosier. It got exactly the same thing. Most people got better, not everybody, and there was nothing obvious clinically as to why there's a difference. So we went back to, sort of the gnawing suspicion, everyone should have the luxury of this result. You get 60%, 50% of people better, and all anybody wants to know is, and so what happened to the other 40%? In a disorder that, the response rate, unless you're looking at ketamine, are really, really modest in this population. The patients had said this in the operating room. We all laughed. We all loved this guy saying, he had 5 children, and he always had all of their friends' kids over, and his comment was in the operating room, it's like I've been locked in a room with 10 screaming children. There's absolutely no constant noise, no rest, no escape. Whatever you just did, the kids just left the building. Now, the neurologist hears this one and goes, next. The patient that says, it's as if I suddenly shifted from a state of all-consuming internal focus to realizing that there's just a number of other things around to do. That sounds like a set shift. That sounds like an attentional deviation. You're going from internally focused, limbically focused, hijacked by some subcortical state, to the cortex, having your brain return to your own function. And we went to look at this very explicitly in the operating room. We alternated the right and left side. We controlled the table, not the surgeon, so to speak, so that we could test on every consecutive contact very consistently what was the change in the pannus as we went from contact to contact. And we would go from the lowest contact up the 4 contacts on each side. Patients didn't know it was on, single blind. I didn't know if it was on because I wasn't controlling the box. And patients would suddenly, you could see it on their face, you could predict it before they opened their mouth, a change, a lightening of their expression to these kinds of statements. All very different, but all very similar. Suddenly just kind of realizing the world was back in focus. And, if I wasn't strapped into this, head holder and I was home, I got some stuff to do. Lawn needs to be mowed, maybe I'll take a shower, got to clean up those dishes, all just activities of daily living. Nothing hedonic. Never that they wanted to go out to eat, go dancing, visit a public place. It was all about just routine back to regular life, which I think is important. Like that quote I showed you, the patient said, you didn't give me anything. This isn't a mood elevator. You took something away. And I think that's a really important point. And the data suggested the same thing. They dropped their negative scores on the pannus. They didn't change their positive scores. And what was very fascinating about this is this predicted their 6-month Hamilton outcome. Now, it's very important that this isn't over-interpreted because last follow-up, we actually had 11 out of the 13 wells, so that it predicted short-term outcome, not long-term outcome. But after 6 months, we changed meds, made more plasmids got more aggressive. But I think it's important because even the trajectory of the change early on was very different. There's something about the reset of starting it. I think it's very much like whatever happens with ketamine or scopolamine. It's changing the balance in these systems, either chemically or electrically, to set these systems into a different motion. So what we did next, and this is like I put this slide together yesterday, is we wanted to try to get even more detail of what is that intraoperative effect, what's driving it. Maybe it'll help us. So this is actually a CT reconstruction. This is the actual CT scan superimposed on the pre-op 3T MRI scan. These are the actual electrodes. One can set up and then superimpose the diffusion data, calculate probabilistic tractography at each one of these contacts. And if one compares the contact that elicited the acute self-report in those 7 patients compared to the contact that was used chronically, best guess, over the 6 months for the intraoperative non-responders, you can start to see the pattern that's different between those two groups that's driving that 6 months effect. They all get the right around the contact. They all get to the nucleus accumbens, but whether or not they reach the full extent of the uncinate fasciculus into the amygdala and hippocampus, only the responders did. And the only ones that get out into the periphery into medial 10 were that group. And we haven't looked at that more closely in a multivariate way yet, but it's obviously very important. If one then looks at the intraoperative responders only and one says, what's the difference between the contact right before you got the effect and the contact where you got the effect in terms of the tracts that were affected? What you see is that the perception of the effect is driven by the medial frontal signal. The active contact and the inactive contact, they both got to the mesial temporal lobe. That's why it's blank, that's a subtraction, so they weren't different. And one can start to imagine now what's driving the perceptual effect, the self-report, the perceptual area that I know where I am in space, the medial frontal cortex, seems to be a really critical driver. And one can start to imagine how one can tune or steer the voltage to actually ensure that you get electricity being driven in those two directions. And we have a new collaboration with Cameron McIntyre to try to model some of this. So the last couple slides is, well, you know, once you get into the operating room and you're hunting for that signal, we haven't moved the electrode. That would obviously be a question. But maybe there's something about picking the patient before we start that might tell us who should never see the inside of an operating room. And this is the extreme exemplar of what we want with every treatment for depression. We want a biomarker. You meet a patient, you scan them, you genotype them, you spin them in a circle, you ask them a question, whatever it is, that we have something that reliably tells us, I know what treatment you need to get well. So we asked that question by looking at the intraoperative responders versus non-responders. We took our target, we did a functional connectivity analysis on the resting fMRI data, and we asked the whole brain, what connection to 25 is important that distinguishes responders from non-responders? And in fact, what we get is our friend the medial frontal on the right side, the dorsal going up the cingulate bundle, and the amygdala. And that actually look at the individual patients in this, the medial frontal perfectly separates all the patients. They don't overlap. So if you have a high connection, a positive connection between 25 and medial frontal, you respond. If you have a negative connection, you're unconnected or negative correlation, you don't respond. And the inverse is true in the amygdala. And this requires a multivariate approach to understand that balance between 25 to medial frontal and 25 to amygdala. Well, we also have started to look at the medial frontal EEG. So we can capture that more real time. We don't have the luxury of an MEG like you have here. But in fact, that the frontal theta power, or even the theta accordance, is actually very different between the people who have the effect and not. It tracks in the same direction. And when you start to look at the literature, including the fabulous work here on predicting the ketamine effect with the MEG, there starts to be this recurrent theme of how the anterior cingulate, the medial frontal, that high activity in this region is predicting recovery. And going back to those first scans in Toronto, which couldn't publish because you can't compare 4 people to 2 people, but we actually had a signal that blood flow was higher in absolute terms in the medial frontal, and the people got better who didn't, even going back then. So we're starting to see some convergence of methods. Now, other people are doing other targets. The ventral capsule, ventral striatum, this is now in clinical trials. The direct stimulation of the nucleus accumbens, these 2 targets are actually kind of merging. They get similar effects. They have different side effect profiles. They produce hypomania. We can't get hypomania no matter what we do. Our bipolar patients get undepressed, unstuck. They don't get manic. So it's an interesting question for further study. We looked and published last year of what might be a clue from the tractography between the target we're exploring and the other target to look for points of intersection. There's got to be something in common of all these techniques that work. There ought to be a unifying hypothesis. And it turns out they all get to the amygdala hippocampus, but I think interestingly they all get to the medial frontal, but they take very different trajectories. So there start to be some important clues of you need to actually modulate certain areas so you don't get better. So obviously, you know, the really important and interesting and important questions are things that I don't do, and I have one more slide. That what is a real-time measure that we can do? Can we look at oscillations? Can we do things, again, going back to Parkinson's? Are there other ways that we can capture real-time what's happening other than really a gross measure of blood flow, metabolism, and integration? It's not giving us the time scale we want. And again, there's a work in progress that in animals, like Hamani did with Teresa Madsen and Tigrani at Emory, stimulating an infralimbic, but in animals that one can do chronic recording and field potentials in the amygdala. So again, Tigrani's expertise is in the amygdala. There isn't a medial 10 in a rat. It'd be nice to have both at the same time because we know that infralimbic and amygdala and infralimbic and medial frontal are both important. So maybe that'll be an idea for you primate electrophysiologists. You can induce even in a normal rat moving around in a cage. It'll become more exploratory at high frequency, but not at very low frequency. You get a very broad change in gamma. And more importantly, you get this very dramatic drop in low frequency power and a tuning and an increase in theta. And that we've started to see if we can get a human correlate of this with acute testing in our patients with frontal theta. And these are people that are turned on for the first time in the EEG lab with EEG. You get an acute drop in frontal theta, and it carries over. But it's very different if you go to low frequency. So frequency is important, timing is important, and there may be important clues between the animals and the patients, and we need to be clever as to try to work this out in parallel studies. And this is very, very similar to the work now on beta oscillations with SDN stim. If you look at beta oscillations in Parkinson's with implanted recording off the electrode, you get a dramatic drop in beta oscillations acutely in the SDN, paralleled in the connection to the GPI, and it's paralleled by a frontal coherence measure in EEG. So there is an abnormality in beta oscillations throughout the Parkinson's brain that one can index. And the question is whether or not there's an abnormal oscillation, an abnormal rhythm in depression that we've never had any reason to look for. So to just end, I find this a sobering but useful curve, because I think anytime anything happens that's new, everybody gets super excited and then you're an idiot if anything goes wrong. I think that one can look historically that this could be a curve for the history of psychiatric surgery, and we're now on the slope of enlightenment, and this is about them. You could equally look at this was the first reaction to brain stimulation for psychiatric illness, but I think we're on this slope of enlightenment. This is not a cure-all. These people need therapy. You enable their brain to be able to recover. They stay well. Our first patients were done in May of 2003. If you got well, you stayed well. People have ups and downs, but you respond to stressors in your environment differently. You can't turn this off, though. People will regress. It happens over 2-3 weeks. When a battery needs to be replaced, they realize they're slow, they have to come back. We don't fix it. Tom and I were talking about the idea is our concept of plasticity is very crude. This circuit is broken. This is an arrhythmia in some ways, metaphorically, that as long as you've got the pacemaker in, you can go about your life doing your thing. But in the absence of a proper rhythm, you can get chest pain when you try to run. And maybe that's a metaphor that we ought to think about in our models. So I just want to end. I found this quote by the lawyer who wrote, Elizabeth Wurtzel, who wrote Prozac Nation. But I think that it's really important to kind of remember what all these interesting experiments help us to learn about the brain. And I think it's really true that people can survive almost anything as long as you can see the end in sight. And for this illness, this is what is robbed. The patients become anosognotic for their past. And then it kind of comes back online and they go, oh, there it is. I see where I'm going. And she described it as a fog, which I think is really, really an interesting expression. And I'll just end by saying I think that what we all do here is that we provide a potential key in this disease and other diseases for patients to get out of those respective fogs. And I'll stop there. All right. I apologize, I went over.
I think we could take 2 minutes for questions.
Yes, Helen, one of the things that you really showed beautifully is that there might be multiple points at which one might intervene in this circuit, and that people are starting to intervene at other locations, including nucleus accumbens. Do you have a sense of what might be the most subtle way to intervene in order to, for example, maintain longer effects and avoid potential problems?
I think that's a really important question that now will have to be addressed. You know, the timeline of all of this is, can you get an effect and does someone want to pursue it to get large enough numbers to actually know if it's worth pursuing further or not? And I think that, you know, just like in Parkinson's, someone went at the globus pallidus, someone else went at the STN, now they go at the PPN, that different nodes are actually responsible for tuning, I think, different elements of the disorder. And different frequencies in movement disorder, I see Dr. Hallett standing, you know, seem to affect different parts of the disorder. And I think the next step is, within a target, understanding how frequency effects may actually be 130 hertz. Why 130 hertz? Could it work at 70 hertz? The rats would say, yes, it could. The Parkinson's people tell me that if you don't have tremor, you do better with your symptoms not to be at 130 hertz and to be at 70 or 60 hertz. I think that the other issue will come up is, do different nodes do better for different subtypes? Right now, everybody's using very similar kinds of patients. That'll need to be explored with bigger numbers where, just like genetics, where you've actually got enough variance that you can look. There's nothing obvious about what symptoms on, say, a Hamilton scale are impacted to kind of speak with certainty about, I think I'm impacting this symptom constellation. I think what is going to emerge is that the capsule and the ventral striatal stem actually does have a mood elevating effect. And when it's turned off, it has what sounds like a crash effect. And again, it hasn't been discussed in the same way, but animal experiments for many years on intracranial self-stim, when you stop providing that, can give you more rapid developing withdrawal effects. And I really would like to see that explored, because that is not something we see in our target that seems to be inferred from descriptions of when the batteries go down in the ventral striatum. So I think the side effect profiles, just like in movement disorder, may at the end, these may all work. There may be nuances of what symptoms are best approximated. You may be able to tune. You may have kind of a narrower or wider band for error. You know, you've got to have people on the street. Well, you know, doctors on the street are going to need to be able to implement this. People are going to expect it to be easy. It was like the transition from tricyclics to SSRIs. a lot easier to use, and people don't tend to get into trouble as easily. So I think that's going to be the transition, and I think that as the numbers evolve, we'll start to have more clarity. It's just
Sounds like all of your stimulation has been bilateral. Have you actually tried to do unilateral stimulation, and what sort of effects would you get just doing one side?
So what's interesting is it's anecdotal. So there was a case in Argentina that actually they had bilateral stim, and for some reason we're tuning it. The person's wasn't as well as they thought, and they turned on the left side only, and the person deteriorated. Changed it to the right side alone. The person got better than they had been bilaterally, and they tried it several times. So anecdote. In Toronto, we had one case where turned it on one side. It had been very dramatic in the operating. Turned out it was the same right side that was best. Turned on the left side the next day. She developed sort of almost like felt a flu, kind of felt slow. I thought she had the flu. Turned it off again, it went away and left her on right-sided stim. If anything, the impression is that the right side seems to be better. And when we've started recently to look at the asymmetry in the tractography, that when you're actually in the operating room, the anatomy of the subcallosal cingulate is very asymmetric. I think it's the left side is always bigger than the right, or I have to look. It goes by handedness, almost to the point where when you see the small one on the wrong side, you ask if they're left-handed, and they tend to be. And we are just starting to look at that. But the tractography is the right-sided tracts go bilateral. They cross over to the contralateral side. The left sides tend to stay ipsilateral. So I think there really is a lateralized effect, that there's not enough pieces to postulate and what would be the right way to do the experiment. Right now, I would guess I would do right-sided stim, but it's not clear if bilateral stim may be competing with each other in some people, that you actually are trying to establish absence of asymmetry, if you're trying to re-equilibrate. This is what Richie Davidson would talk about with the right-left asymmetries that I never knew what to do with, and now I'm gone back to read those papers.
Well, actually, just sort of comment on that. In terms of RTMS effects, if you use rapid RTMS in the left hemisphere, it works, but slow RTMS in the right hemisphere, it works. So it seems if you increase activity in the left hemisphere or decrease activity in the right hemisphere, you get a similar type of effect. So it does look like there's a sort of a counterbalance on the two hemispheres in some way.
And I think in the patients that only get, a third of the way well, the question is should we drop the frequency some? Or should we actually turn off one side? And I think that's something we're discussing based on at least the anatomical data. So it's a very interesting suggestion.
Well, thank you. Let's keep the conversation going. There's a reception that will happen in the library through these doors. And once again, let's thank Helen for an outstanding presentation.